So what we'll do is, we've done before, we'll take the two papers, 20 minutes each, and then open up for discussion. So Robert, over to you.
Okay. Is it going to be easy if can you hear better if I stand up? Generally. Yeah. Generally. I want to try and tackle a quite difficult area, but a very specific area. And it's again with a question which I've been asking myself throughout this conference about how the church can actually negotiate ethical issues in society at large. And we've had a number of views on this and the tensions of them. Jonathan just now mentioned John Rawls. And John Rawls was a very interesting example of a secular political philosopher who came slowly and eventually to allowing some room for faith groups in discussions. The book you mentioned, 1972, his great theory of justice, was really supposed to be the definitive answer about how you can get a purely secular understanding of justice, and was a brave attempt to do that. But ultimately a flawed attempt as well. He really thought enlightened self-interest of a particular type, filtered through a rather Kantian framework, really could answer the question. And that's, if we're all ignorant of our future, there's a veil of ignorance over each one of us, and we really don't know what's going to happen to us, then it's in each of our self-interest to care for those in need. That's the theory, in a nutshell. The trouble was, and I think this eventually occurred to him, is that the most indulgent people, most self-interested people, won't be the slightest bit interested in the veil of ignorance. What they want to make sure is that they will get more than they deserve, not what they deserve, but more than they deserve. And indeed, the most deviant people are the ones who manage to persuade other people to give them much more than they deserve. So just relying upon this general idea of how people ought to behave, the most indulgent people are not the slightest bit interested in that. They just want to benefit themselves. Eventually, I think this led him, whether that was the factor or not, but he undoubtedly had criticism. And eventually he made some room for faith groups, realizing that there were different voices. But he said there's a condition. If faith groups want to take part in these discussions, they must use public language. They can't use faith language. And there's a lot of common sense in that position, and I must say it's largely been the position I've taken. I've worked a lot in national medical ethics groups over the last 30 years, and that is primarily the position I take. But, and this is the big but, they know I'm a priest, and then I'm a theologian. So I don't have to talk about God today, because they know that's part of my baggage, so to speak, and they know where I'm coming from. What they don't want me to do is start preaching. And I think this is rather an English perspective. I use that word English here rather than British. After all, our troubles, particularly in your period of history, and the gruesome clashes over religion, there's kind of a truce in English society, it seems to me, that if we don't try to impose on each other our religious beliefs, we're free to hold those beliefs and indeed derive values from them, as long as we don't do too much preaching to other people. And I think there's some wisdom in that, and I must say I always defy some of the more strident theologians who believe they can do medical ethics on secular committees while using explicitly religious language. I always defy them and say, well, try and see what happens. And almost immediately what will happen is somebody will stand up at the committee and say, well, that's not my belief, why are you imposing it on me? And I think it's one of the problems the bishops have had sometimes in the House of Lords, particularly with euthanasia debate. I don't even remember John Hadgood, after a string of bishops, had said, as a Christian, I do not believe in euthanasia. And the secretary simply said, well, I'm not a Christian, but I do believe in new things. Why do you expect me to follow that? John Hadgood of Fincham stood up and said, "You will not hear a breath of theology from me to the House of Lords." And he went into rational arguments about why he didn't support euthanasia. I remember speaking to him about that and said, well, I admired that. And he said, well, I think the others haven't been in this business as long as I have. So there is some wisdom in that, but there's also a danger, of course, that we appear faithless as a result of taking that stance. I've also adopted the attitude that really is most helpful to have people who really are experts already in the field if they are going to be theologians trying to work in this kind of area. And that's absolutely essential, that you do have to learn the language and you have to understand what you're hearing. And my favourite example of that was John Polkinghorne, who I got to know quite well, particularly in the later stages of his life. And I always admired the fact that he could speak with authority in his scientific area before he started pontificating about the theology of it. And that's pretty important, and I know quite a few who are experts in their own areas, and how annoying it is to have non-expert theologians telling you what you should think. Well, St. Jonathan, like one, yes. I wanted to explore the most intractable area in healthcare ethics, and it's about distributed justice. It's the area of rationing or priorities. I mean, of all the areas in healthcare ethics, which is really intangible, it is rationing or prioritizing. And as it happens, at just a moment, that couldn't be more important in terms of what we're seeing with the health service. How we can get a rational approach or ethical approach to rationing. And it becomes particularly crucial, and this is where distributive justice the approach really is, when there's a great demand and a need for something, but only limited resources to meet that. It's fine to talk about equality of justice across areas which don't actually affect resources. We all have a right, for example, to have a fair trial and a presumption of innocence, for example. And that is mostly not questioned. We can have that. But the idea that you have a right to a particular form of treatment, which is scarce and will be denied to other people, becomes much more contentious and much more difficult to handle, much more difficult to work out. Well, twice in my life I've worked with real experts in the empirical and scientific area involved in these questions. I once was at the University of Kent, where I worked closely with John Butler. If you remember, he was a sociologist by background. He founded the healthcare studies at the University of Kent and became an international expert in healthcare studies. He also happened to be a Methodist lay preacher, and a respected one too. Although he's left Canterbury now, but he's here for many, many years. Well, he decided at one point, he really did want to explore this idea of rationing and healthcare priorities from an ethical perspective, which outside his normal remit of sociology. So, how to make normative judgments, not just scientific or social scientific judgments. And he asked me to help him with writing a book on this, which I was delighted to do. And this was the book. The Ethics of Healthcare Rationing came out in 1999. And it's a very good and very clear book, and I used to use it a lot in teaching. But in one respect, I totally failed in directing. I wanted him really to bring in his Christian faith, his experience as a Methodist, into what he was doing. And he was very wary about this, probably because of John Moore's public reasoning, I'm not sure. Or maybe his own diffidences about doing theology. But what he did is he came almost near it, but not quite. And what he explores in that book is some of the social factors involved in rationing. And he says, well, there's two ways of doing it. You can do it explicitly or implicitly, rationing. If you do it explicitly, well, surely that is the preferred way. You're upfront about what you're doing. Well, how do you achieve that to get some social consensus? Well, he explored a number of ways of doing that, and one of the ways was the way of Oregon and New Zealand at the time, where they actually had social surveys, and they asked people, and they got discussion groups and ethical groups to come and talk and discuss this, and try to do this democratically, so to speak, and get what does the public really want. And that sounds very good, doesn't it? Except for the fact, if they were unprompted, they had all sorts of strong ideas about treatment of children, of course, priorities, intended to exclude the elderly, but they completely forgot about areas like accident emergency, which we just expect to be there. But it didn't occur to them until they were prompted about that. And then it became fairly obvious from looking at the service that people really were all over the place. They had particular prejudices and particular ideas, but it wasn't clear they had a clear overview of how one thing should be preferred to another thing in terms of how you actually allocate resources. So he said, well, there are a number of implicit ways of healthcare rationing. They're not upfront, so to speak. The one that's become most obvious to us at the moment is queuing. So you queue, well, you must be aware of this. You queue to get an appointment with your GP. Once you've seen your GP, you'll then get another queue to see if you go to a specialist. And once you're on the specialist queue, you have that specialist queue about when that specialist can see you. And then when you've seen that specialist, if it's a surgeon, you then get another queue to when you actually get your operation. So years down the line, of course, you may eventually, or you may not, get the operation or whatever it is you think you need. So the queuing is one way of doing it, but there are others, and quite a number of others. But that doesn't necessarily ensure fairness, of course. And that breaks down. Or one famous theory at the time, still is, I suppose, was QALYs. Quality life-adjusted years. So you try to work out on the basis of how many extra years does treatment give a particular patient of healthy and well-being years. Now that sounds very good, but it does sort of work, and it's one of the most rational theories going. But it has drawbacks again, and John points this out. For a start, you really only treat babies, never old people. So anybody of my age or older, you forget about them, and you only treat young babies and small children, because of course they have potentially the greatest number of years ahead of them. Yes, yes, I can see the point, and I might almost support it, but that leads to problems as well. And anyway, who is it who does the assessing of what well-being is? So is it some sort of, does a disability mean somebody's not got well-being? Or, we've all got disabilities of one sort or another, but people with most serious disabilities vary hugely in terms of whether they feel their life fulfilled or well-being, despite or even because of their disability. So those kind of problems very quickly arise there as well. And there are other problems with QALYs as well, but I won't go into all of them. What he eventually concludes, and this is sort of helpful but also unhelpful, he concludes that there isn't a rational basis for all these things that everybody can agree on. Which rather begs the question, well, yes, but often we exclude faith positions because they're not held by everybody else. But if you actually, you don't have to work too long on a medical ethics committee to realise that actually the philosophers are just as divided amongst themselves as are the lawyers. And they're coming with supposedly rational and agreed positions, but of course they're not. and the utilitarians and the Kantians and all the rest of it are each other's throats on those committees. So we're kind of agreement there. But I still couldn't get John over the hurdle of trying to say, well, what about his Christian faith? What difference does that make? We avoided that. At last, 20 years later, almost 30 years later, I found somebody who could jump over that barrier. And this is the book it's only very recently out. Stephen Duckett, incredibly expensive, you had to get it through the library. It'll come a paperback in a couple of years' time. Healthcare Funding and Christian Ethics. This is the series I edit for Cambridge and have done for 30 years. But it's the most recent one. Stephen Duckett is an international expert, an Australian, international expert on healthcare economics. That's his area. He's an honorary professor at Melbourne in this, and he's a well-respected policy advisor in healthcare funding across quite a number of countries, including Australia. So he comes with huge credentials in this area as an economist. But he also happens to be a lay reader as well. Lay reader in Anglican, not lay preacher.
3 more minutes from now.
Right. Might be a little bit long. So he came with all these high-class economic theories, which he negotiated regularly, using qualities sometimes up to a point, but and using other ones as well. But what he did is he crossed the threshold. I challenged him and said, you as a Christian, other virtues that you bring as a Christian in your own life, can you bring them into your healthcare economics? Well, he responded to that and identified eventually the Good Samaritan as the parable that he found most helpful. It starts with compassion. The word compassion, splagnetes, the Greek word is right up there in the middle of the parable, as it is for the prodigal son. Rarely used otherwise. It means with guts are wrenched, quite literally. That's there. There's clear stewardship at the end of the parable, that the person actually does something. You can call it a fair all along, and particularly Stephen. Yes, he actually does something. And he puts his money in his own pocket and he makes provision for the person. And in the middle, there's all sorts of stuff about equality as well, because after all, this is a Samaritan and a Jew. So it crosses that divide too. Now, he says he thinks that really is missing from his professional work as a healthcare economist. And he's really now challenging in this book his other healthcare economists and saying, well, we're not dealing just with statistical people, we're dealing with people. And to them we must be showing compassion. Of course we have to work out rationally what we can do, as far as we can do it, but we can never lose sight of the fact that there are people in need. Compassion, the need for that. And stewardship, that we do need to use our resources carefully and prudently and in a way that responds to our faith drivers. Stewardship, particularly, and compassion. And equality in the middle there, which is probably shared across secular and religious divides. Now, I found this really quite inspiring. How far he actually managed to persuade other economists, of course, is another question. But at last, I found somebody to try to use his professional expertise to articulate how we can introduce Christian virtues within that.
Great, thank you.
Thank you very much.
Okay, thank you very much, Robin. So we move on to Stacey, who is talking to us about social justice and adult social care in relation to the Church of England.
Thank you. Hopefully everyone can see and hear me. So just to give a very brief little bit of background to perhaps understand where I'm coming from. So I work at the University of Kent. I'm in the area of social policy, but our wider division's recently been renamed to Law, Society and Social Justice. So we don't really see social policy and social justice in tension. Actually, there's a synergy and lots of overlaps. I'm here to talk about my main focus of work, which is adult social care, and hopefully in the next 20 minutes going to give you a bit of an overview, a little bit of understanding about what social care is, how it relates to social justice, and also linking then to the church, and I've added of England because I think it needs a little bit of a narrower focus. So to the first slide, please. So I'd like to just spend a minute or two thinking about what actually is adult social care. I find that when I talk to people about what I do, people seem to think they know, but often in conversation I find there are lots of misunderstandings. This is becoming less frequent because in the last couple of years particularly, social care has been in the news a lot, so I'm getting the impression that people are more aware. But just very briefly, what adult social care is about the network of support that's available for people aged 18 and over who need some kind of help for a whole range of different reasons. So this is disabled people, people living with long-term health conditions or chronic illness, people with mental health problems, enduring mental health problems. It includes people experiencing homelessness and also refugees. So it's a very broad range of people and very diverse set of needs. And often in the media, the focus seems to be on older adults. And yes, it is true that about 70% of our spending on social care is for adults aged 65 and over. But there's also a substantial amount of need for working age adults. So these are people who are perhaps born with a disability or living with a disability of working age, including adults with a learning disability or intellectual disability. And the other common misconception I think that people have is that I'm talking about social care and they're thinking I'm only working in the area of statutory services, so social care that's managed or paid for by local authorities. Now that's an important part of our setup. And many of you will know it's not like the NHS, it's not free at the point of access, but we have a safety net system. So we have statutory care for those who don't have over £23,500 of savings. So that's part of what I do, but actually adult social care is much broader. We're also talking about people who privately purchase care, that in the home or in care homes. It includes the voluntary sector and third sector organisations, and actually includes churches. So many people don't realise, but the work I do includes the action of faith communities and churches. And I think really importantly, also the informal care by family and friends. So in my work, I'm taking a very broad view, looking at all of those. And my particular interests are around the quality of care, so that's formal care services, and also policies to do with family carers. So how a family care is understood in the way in which the state interacts and engages with them. So hopefully that gives everyone a bit of an idea of what we're talking about. Next slide, please. Now, having said all of that, I've given you an idea of what adult social care looks like in terms of the key players. But I'd narrow it down to an even shorter definition, that adult social care is about supporting people to live well and to flourish. And I think this is at the heart of what adult social care is trying to do. Now, many people might, when you say social care, think about care homes or perhaps home care workers coming into the home. And people might think about tasks like someone being helped to get dressed or help with eating. And these are parts of what you see happening, but actually the fundamental desire or aim behind all of this is enabling people to have a good quality of life, to live in a way in which they're respected as a human being, that they have dignity, that they're able to have some choice and control about their lives, live ordinary lives in ordinary ways. And I think that's really important. And when you talk to people working in this sector, there's usually a lot of passion around this particular concept. So it isn't just me who gets passionate about this. Next slide, please. And just to reassure you, it's not just people being passionate, we've also got the backing of other things. So we've got in England legislation, the Care Act 2014, which sets out the duties on local authorities who are responsible for social care. And at the heart of that legislation and the action of local authorities is well-being, individuals' well-being. And that's both adults with support needs and also family carers. And there's a lot been said and written about this, and many people point at the failings and limitations of the current system, which are absolutely there, including in the recent House of Lords Commission, where they talked about these. But we still have that aspiration, and it's there in our legislation. Secondly, we have a regulator, the Care Quality Commission, and they're also looking at similar things to what I've talked about. So if they go into a care home or they look at a home care agency and they can see a care worker supporting someone to eat and drink, they're not just seeing does it happen and they're ticking a box, they're wanting to understand the quality of how people are working and engaging. And finally, I've put there something that's called ASCOT. This isn't anything to do with horses and silly hats. This is a way of measuring and understanding the quality of care. It's the Adult Social Care Outcomes Toolkit. And rather than going in and asking how many hours of home care, how many home care workers and so on, it's instead asking, well, the people receiving care, how has that care improved their lives? How is it making them live a better life, to live well, to stay connected with family and friends, to be able to dress in the way they want to, and these other kinds of things. So you can see that this definition of adult social care is really central in certainly the aspiration, if not in the actual practice and delivery. So next slide, please. So just to think a little bit about social justice, I've got two slides here, and just to draw out two areas where I think questions of justice are particularly strong when thinking about adult social care. The first one is thinking around the overlaps with poverty and inequality. And I'm going to draw out a few thoughts around both adults with support needs, their family carers, and also the workforce. There's three areas or three key groups of stakeholders who are involved in this network. Now we know that lots of people need care and receive care, and I'd imagine in this room pretty much everyone here will know someone who receives care or has known someone who does. But what we actually know from the evidence is that individuals living in socially deprived areas are more likely to develop healthcare needs. So as much as you get health disparities, you also get care disparities. And also, if you don't have your own resources, there's a whole number of issues about accessing care. So as Robin was talking about rationing of healthcare, you also get rationing of social care, something I've written about. And that's particularly a problem with statutory services. We've got a limited amount of money, and so some really tough decisions have to be made about who gets services and in what way. Thinking about family and friends, one thing I would say is that caring for a family member can be a really rewarding thing to do. And again, I'm sure many people in this room will have had direct experience of that. But we also know that caring for a loved one can, in certain circumstances, be a risk for developing health issues of one's own, particularly if you're looking after someone who needs 24/7 support. It can also have an impact on someone's ability to, if they're of working age, carry on with their job, and that can have financial impacts and also push people into poverty. So there was a really great report that came out by the ONS 2 years ago, and it talked about caring as a social determinant of health. So it's understanding that the experience of caring, as rewarding as it can also be a social issue in the individuals who are caring may end up with issues, financial issues, health issues of their own. And finally, the care workforce. Again, this has been in the media, so I hope this isn't new, but we've got a whole range of issues around low pay, poor working conditions, which are really an issue. And I've got a colleague who's written about this and actually talks about care wages as poverty pay. So there's something about, are people really earning enough to live on? And alongside that, I don't want to sensationalise, and this certainly isn't a sector with the biggest issue, but we do need to talk around modern slavery and human trafficking. So adult social care in the UK and England is very highly regulated. So this isn't a huge issue. In some other countries it's more of an issue, but this is definitely there, that kind of underground or sort of unseen market of care workers. And the next slide, so as well as this, I think we also need to name issues to do with discrimination and stigma and social exclusion. So something that's sadly known, I've seen this in my own work, and I've got a PhD student who's working on this, that individuals with disabilities do experience exclusion and stigma, as do family carers. That's something I've found in my own work. But we know that there's intersections, so people don't just come as a carer or someone with support needs. They have a background, they come from a particular area, they're of a particular ethnicity, speak a certain language, have a sexuality, they're full human beings. And sometimes some of these characteristics mean that they're at higher risk of discrimination and stigma. I've got a colleague who's doing some great work about LGBTQ plus people in care homes. There's other researchers working at this space, looking at that issue and how to address it. And a question I think that's really important, you see that some groups of people are less likely to access services. Sometimes that's interpreted because they don't need it, but actually, are they being excluded by what's on offer? So justice, quite a big justice issue. And also during the pandemic, I think we're very aware of issues to do with digital inclusion and exclusion, as many care services are pushing to have, for example, an online system to request support. Some individuals just may simply not have access because either they don't know how to use the technology or they can't afford it. So I think this is hopefully giving a flavour that there's lots of slants of justice issues here. So to the next slide, please. And underpinning all of this is, I know we've had elephants in the room talked about before, but I think the biggest one is how do we pay for care and how do we find fairness in that? And I'd say there's not just one elephant, but multiple elephants in the room. You do sometimes get people, I've had this when I've talked to people, they say, well, why is this suddenly now a problem? Families just used to care for their people and everything was fine, so why is it a problem now? Now, I think these are the other elephants in the room. So we're an ageing population, which some people frame as a bad thing, but I'd say it's a good thing. We're living for longer, but we're also living for longer with more health conditions, chronic health conditions, which is then driving a greater need for care. We're also a country that's ageing without children, and you see that in successive cohorts. That more and more people are getting to the age of 40 without having had children of their own for a whole raft of reasons, including the climate crisis, as was alluded to earlier. And with these two things together, and also not just not having biological children, but also those children being more mobile, so moving around the country or internationally. And these two things together mean that there's a growing demand for care and that there isn't that family support that you would necessarily fall back on. And again, I love party conference season because pretty much every year, at least one person, if not multiple people, will say, we'll fix the social care crisis by getting people to have more children. And I would really caveat that as a policy approach and think that this is just trying to avoid naming and actually tackling some of these big questions, which I think are really important ethical questions of our time. Go to the next slide, please. So I'm very glad to have seen that the Church of England has been engaging with this, and many of you will have seen that we've had the Archbishop's Commissions recently, and one of those was on adult social care. I know earlier it was kind of alluded to that this work perhaps was not getting much traction, but I've got to say in my working life, among colleagues working in adult social care, this was very well received, this report. It seemed to hit the right kinds of notes, and I was actually in an entirely secular meeting where it was actually put on the slide and said this was an example of some good work. So I think there's some real positives coming out of this. Perhaps one of the slight negatives is it seems to be a group of the usual suspects. So So we've had a group of reports recently, this work and also the House of Lords commissions and other reports. But I don't necessarily think that's a bad thing, because we just need to keep pushing this forward and keep it on the agenda. So to the next slide, please. So if you haven't read the report, this quote from the conclusion I think really sums it up nicely. The Commission is arguing that in order to reimagine care and support, we must uphold values that recognise the dignity, value and gift of every human being. This requires us to take action towards rethinking attitudes to care and support, rebalancing roles and responsibilities, and radically redesigning the system. So I think 3 R's helping us, but just to give a bit of a flavour. Rethinking attitudes is about tackling some of the ageism that we see in language, some of the language that's actually discriminatory towards people with disabilities, and trying to move away from a language of seeing people as burdens towards seeing them as gifts. Rebalancing roles is particularly pushing forward the idea of having a national care service like the NHS, so having a better structured care system. And I've got to say that there are both pros and cons of that, so I'd bracket that, but maybe something that will come up in questions. And radical redesign is about thinking in a much broader way, so rather than silos, thinking about the way in which care is related to other aspects of our lives, particularly housing. So in my work, one of the biggest drivers of how well someone lives if they've got care and support needs is their housing. Is it suitable? Can they move about? Can they get to what they need to? If there's someone who's suddenly got mobility needs and they can't get in the kitchen and cook a dinner, that's actually quite a big problem. So how are we thinking about our housing and making sure it's adaptable for people with a range of needs? And also under this last one, radically redesigning the system, it tackles some of these issues about workforce and fair pay, which I think are really, really important. So overall, I think a really great report really engages with some of the issues in breadth and gives us some good things to get our teeth into. Next slide, please. But I've drawn out a few areas where I thought maybe things were missing or I had questions. So the first one was about rethinking attitudes, and one question I had is our theology part of the issue? And those of you who know me do know I spend a lot of time going around churches and listening to sermons and intercessions and thinking about language. So when we're praying for people or talking about people, what language are we using? What's that saying about our theology and how we think about people? Maybe that paternalism that we talked about earlier, is that coming through? Are we seeing people as gifts, not burdens, but also as mutual, people with whom we mutually engage as equals? I think that's really important. About rebalancing roles, a question I have, particularly in our current context where we're perhaps declining, is do we really have the skills and expertise and resource to safely and effectively deliver care? So one of the suggestions was how churches could get more involved in social care. We're already doing a lot. But my question would be to take a step back and think about that question really carefully. In some circumstances, the answer is absolutely yes, but I'm not sure it always is. And I was really quite surprised that the report didn't engage with that question of safety and safeguarding. We know that that's actually really crucial in adult social care. And finally, recognising and valuing carers among our clergy and our staff in ministry. And this is something, again, that I've seen. So there's lots in the report saying that carers need support and encouraging that. But what about the ways in which we work, our workplace cultures? For example, clergy work 6 days a week. If they suddenly then need to be doing family care alongside that, that is really tough. And I know that this is happening because I know that colleagues are doing it and I hear about it and the stresses it produces. So if we're going out with this report and encouraging others, then I wonder, should we be thinking about this as well? So a few challenges. Next, thank you. Oh, this should be fine, nearly there. So in terms of a few quick wins, so I've put some challenges in. This is for anyone here involved in local churches or interested. A few things that I'd suggest. So as I've alluded to before, thinking about language in our sermons and intercessions and newsletters, perhaps paying attention to how we're talking about people, and if we're not sure, this is always a good opportunity to ask people to get feedback from others. There's a good thing about kind of engaging with the community and getting a little bit of feedback and doing an audit, so it's accessibility not only of our buildings but how we talk about one another. Rebalancing roles, so thinking about where we as churches are already active. I would really encourage everyone here, particularly involved in churches, to think about where are you already doing social care. If you're running a lunch club or doing anything with older adults or disabled adults, you're already out there doing this. So be a bit bolder and accept what you're doing and be willing to engage. Then I've put think carer. So again, I saw some nods when I was talking about caring. Are you caring for a family member, or do you know others who are? Be aware of that. And there are local organisations that you can link people to, and churches play a really important role in linking and signposting, working in partnership. And that final point, again, linking in, is we're not here doing this alone, we're working in partnership with others. So be willing to do that. So on to the final slide. Thank you. So just to draw things together, I haven't spoken much about the theology of this, but I have done a little bit of work in the space. So I've written an article which was published in the journal Theology, taking this in a bit more depth. I won't say much more here, but I would say if you're interested, then there's the link, or I'm happy to chat to people. And if anyone wants to hear more, then you know where I am. Do get in contact, and I'm always happy to speak. Thank you.
Thank you very much.